Hello guys, welcome to the part 2 of hypertension pharmacology. And yesterday we talked about direct renin inhibitors, ACE inhibitors, and ARB blockers. These are the three classes which we discussed last lecture, and also we have discussed about the RAS system, and side by side we have listed out the drugs, okay, for these three classes. And now we are going to continue with calcium channel blockers, sympathetic agent, vasodilators, and diuretics today. So now, starting with the calcium channel blockers. Now, the calcium channel blocker, the main thing of the calcium channel blocker is peripheral vasodilation. The mechanism of action, peripheral vasodilation. This is the main mechanism of action, and calcium channel blocker don't do anything else for the main mechanism of action. Main mechanism of action is peripheral vasodilation. How it is administered? So administration is about oral and IV. Okay, now one more point gets added in this calcium channel blocker. It's classification. So in short, we will write calcium channel blocker as CCB. Okay, now it is a very interesting classification as it will help you in telling the uses of the drugs of various calcium channel blockers. Okay, so now the classification states that calcium channel blocker are of DHP types and non-DHP type. Okay, now what is this DHP? So this DHP is dihydropyridine. Let me just write it somewhere. Dihydropyridine receptors. So going back to physiology, we have learned it that EC coupling kind of thing, there are dihydropyridine receptors. Okay, these are the dihydropyridine receptors. Okay, so calcium channel blockers are of DHP types and non-DHP type. Under DHP type, we see the drugs which has the suffix named as dipins. Okay, all the dipins. And under non-DHP types, we have two drugs. Okay, we have, just a second, we have diltiazem, and we have verapamil. Okay, you should know the names of these three, what can we say, concept. This is the dipins. Okay, diltiazem is a specific drug and verapamil is also a specific drug. Now I was talking about you will know the uses, but first you should know one thing, on which receptors or on which DHP receptors, or to be specific, where do the DHP receptors are present. Okay, they are present on the blood vessels, then on muscles, and also on heart. Okay, so the DHP types or the dipins, okay, they act on blood vessels. Okay, only blood vessels. Then verapamil acts only on heart. Okay, mark this, very important. You will get to know why I am saying this. Okay, actually we are studying calcium channel blocker in much more detail today, and hypertension is one part of it. Okay, so and diltiazem acts on both. Okay, so can we say that verapamil is cardiospecific? Okay, now what happens is the main mechanism of action is peripheral vasodilation. So technically speaking, vasodilation will cause decrease in blood pressure. So the blood pressure kind of thing is now solved. Okay, now what happens is one mechanism we will study of this DHP receptor, DHP type or depends. Okay, so what is the action? It acts only on blood vessels, so the blood vessels are dilated, and specifically artery. Okay, artery specifically. Okay, now what happens is, when the blood vessels get dilated, we see a decrease in BP. Okay, so if the BP decreases very much, okay, so what happens is, decrease in BP, so we see a reflex sympathetic action. Okay, sympathetic discharge. And what this sympathetic discharge will do? It will cause a reflex tachycardia. Okay, and this reflex tachycardia is very dangerous. Okay, because there is sudden increase in the heart rate and it leads to increased oxygen demand. Okay, so to prevent this, the depends are combined as a FDC with beta blockers. Okay, now we have seen that the diltiazem acts on both and verapamil acts only on heart. So what will happen is, the calcium channels are present on SA node and AV node. Okay, and in diltiazem we have also additionally the blood vessels. But if we block the SA node, okay, what will happen? SA node is responsible for the normal sinus rhythm. Yes, so if SA node is blocked, the rhythm will get decreased. Okay, and it will cause bradycardia. And if the AV node blocks, we will see AV block. Okay, so one thing to be noted here, this non-DHP types will be contraindicated in, yes, you are right, heart blocks. And if there is problem with the SA or AV node. Okay, now tell me one thing, if we combine this non-DHP types of calcium channel blocker with beta blockers, what will be the effect? So we have seen that this non-DHP types act on SA node, AV node and blood vessels. Okay, means diltiazem acts on additionally blood vessels. Now already we have seen that if it acts on SA node, it blocks the calcium channel there and it will cause bradycardia. If we see the AV node, the AV node block will cause AV block, the 2 degree and 3 degree blocks. Okay, and if we additionally combine beta blockers, it will prevent the tachycardia kind of thing. But tachycardia is not seen in case of non-DHP type. The rhythm, which is actually normal, it will be decreased more due to the non-DHP types, and due to the beta blockers it will be reduced further, and this will cause cardiac arrest. So note, the non-DHP types is never combined with beta blockers. Okay, now going to the drugs. Okay, let me just write it here, drugs. The name of the drugs coming under depends is amlodipine, we have nifedipine, then we have nicardipine, then we have clenidipine. And lastly we have nimodipine. Okay, so this is oral and longest. Okay, knife, the nicardipine. Nicardipine is IV longest. Okay, so A and N, amlodipine, nicardipine. Amlodipine is oral and longest, and nicardipine is IV longest. Then we have nimodipine. Nimodipine, M word is coming, so it is crosses the blood brain barrier. M means meninges, so it crosses the meninges or the blood brain barrier. Okay, and amlodipine is generally given as a add-on drug in hypertension. Okay, and nicardipine, since it is a IV drug, it is given in, yes, you guessed it right, since it is a IV drug, it is given in hypertensive emergency. Okay, now going to the drugs verapamil and diltiazem. Let me just write is diltiazem. Now diltiazem, as we have seen, it acts on both. Now tell me one condition of the heart and the blood vessels where both are affected, and it is a very common condition. Yes, angina pectoris. So it is a drug of choice, or it is a add-on drug in case of, let me just, treatment of angina. Okay, and then it is preferred for hypertension. Okay, now the diltiazem, okay, we have side effects like flushing, edema. We will summarize the side effect of all the calcium channel blocker after, but the common side effects are edema, flushing because of vasodilation. Then we have the verapamil. Okay, verapamil, we have seen that it acts on heart. It is a cardio-specific drug. Now tell me one thing, the disease, okay, one condition where the heart is affected because of its rhythm. We have seen that it acts on SA node and AV node. Verapamil acts on SA node and AV node. So when there is a problem with the SA node or AV node, the condition is called? Yeah, you guessed it right. It is known as arrhythmias. So treatment of arrhythmia. Okay, and specifically the SVT, then we have the flutters, then we have the fibrillation. What is SVT? Superior ventricular tachycardia. Okay, first year physiology. Then also sometimes we can give verapamil and treatment of migraine. Okay, it is an oral drug and it is a CYP3A4 inhibitor, so drug interactions are increased. Now going to the side effects. We have the mnemonic, just a second. Hypertensives usually for get calcium channel blocker. Now side effects is, what is H? Stand for headache. Headache is most common. Then we have U, urinary retention. Okay, then we have F for flushing, as I mentioned earlier. Then we have O, edema. R, it decreases, or better we write reduces BP. Okay. Then GE is for GERD, gastroesophageal reflux disease. T is tocolytic, and CCB is constipation. Very vague and very random side effects, but if you remember this mnemonic, you will remember the side effects. The hypertensives usually forget calcium channel blockers. So headache, then we have urinary retention, then we have flushing, edema, then we have reduction in BP, then we have GERD, gastroesophageal reflux disease, then we have the constipation and tocolytic. Okay, so this was it for calcium channel blockers. Okay, now we will start sympathetolytics, and in sympathetolytics we will study first about peripherally acting and then centrally acting. Under peripherally acting we see beta adrenergic blockers. Okay, so this beta adrenergic blockers commonly called as, and we have listened about many drugs about beta blockers, which are propranolol or timolol or metrolol, etinolol, ismolol, which are used frequently. Now, what is the mechanism of action? So we have selective beta blockers and we have non-selective beta blockers. As we know, selective beta blockers, it blocks only beta 1, and non-selective blocks beta 1, beta 2. Now tell me one thing, beta 1 and beta 2, where are the receptors? Okay, so we know that beta 1 receptors are on the kidney and heart, and beta 2 receptors are on the smooth muscle, liver, and SLS, smooth muscle, liver, and skeletal muscles. Okay, now if we block beta 1, okay, let me just scribble it somewhere, so I will scribble it here. So if we block beta 1, we have heart, we have kidney. Now if we block beta 1 on the heart, it will reduce the heart rate, reduce the force of contraction, and reduce the cardiac output. And what about kidney? It will decrease the renin levels. Okay, so this is the mechanism of action. Okay, so decrease, first we will write heart. On heart we have decrease heart rate, decrease cardiac output, decrease force of contraction, sorry, it should be decrease cardiac heart rate, decrease force of contraction, decrease cardiac output, and therefore decrease BP. And on kidney we have decreased renin levels. So if decreased renin levels, angiotensinogen to angiotensin will be converted less, and angiotensin 2 will be obtained less, and therefore we will see decrease in the BP. Okay, now administration. What about the administration? They are oral drugs. Okay, beta blockers, propranolol and all, but we can also give it as a IV drug, which is ismolol, or we can give betoxolol as IV drug. Okay, what are the drugs? So this is a bit tedious process. We have beta 1, we have beta 2, sorry, beta 1 and beta 2, and beta 1, selective and non-selective. Selective is beta 1 and beta 1, beta 2 is non-selective. So non-selective we have two drugs, propranolol, pranolol, we have timolol. Under beta 1 we have etinolol, we have metprolol, we have ismolol, okay, and we have betaxolol. So selective, under selective we have 4 drugs, under non-selective we have 2 drugs. Okay, what are the uses? Now one specific use of beta blockers is hypertension, but with increased renin levels in children. Okay, with hypertension. Okay, young hypertensives. Now the side effects. So side effects, basically I will not call it as a side effect, but it can cause bronchospasm in susceptible individuals. Who are the susceptible individuals? Yes, you guessed it right. They are the allergic patient. For example, they have allergy of pollens, and if they take the pollen and they started taking that they started acting allergic, the bronchospasm will occur. And if we take beta blockers, the bronchospasm will worsen. So in allergic patient, contraindicated beta blockers is observed. Okay, now going to centrally acting. Okay, centrally acting means it causes blood-brain barrier. They are more lipid soluble. Okay, and we should give a transdermal patch for its sustained use. Okay, now what is the mechanism of action? Since it causes blood-brain barrier, it goes to the brain. Okay, logically. Now when it goes to the brain, it acts, let me just write it, it acts on alpha 2A receptors. And remember, alpha 2A receptors, okay, what will it do? It will decrease sympathetic outflow. Okay, and alpha 1 receptor peripherally. Okay, we have learned that alpha 1 receptor. What does alpha 1 receptor do and where it is present? It is present on blood vessel. Okay, and it will decrease the peripheral vascular resistance. On heart, it will decrease heart rate, cardiac output. Okay, this is the mechanism of action of one drug, one famous centrally acting sympathetolytic, clonidine. Okay, it is a centrally acting antihypertensive agent. It will act on brain, cause decreased sympathetic outflow, on blood vessel, decrease peripheral vascular resistance, and on heart, it will decrease heart rate and cardiac output. And remember, any sympathetolytic drug, it is used in chronic hypertension. Okay, why chronic hypertension? Because the peripheral vascular resistance, to decrease it requires time. So the BP will be decreased a bit later. So in chronic conditions, we use the sympathetolytics. Okay, now the mechanism of action is done. The administration. Now administration, we have transdermal patch, best. Okay, it is the best mode of administration because it will sustainably release the medicine, and also the frequency of medication is reduced. Okay, transdermal patch of clonidine, basically it decreases the blood pressure for a week or so. Okay, then we have the adverse effect. The adverse effect is, since it acts on the CNS, dryness of mouth, eyes, then we have depression, CNS, so sedation, vasodilation, so we have bradycardia, vaguely, impotence. Okay, these are the some side effects. One class of drug yet to be spoken of sympathetolytic is alpha blockers. Okay, so in alpha blockers we have non-selective and selective, just like beta blockers. We have alpha 1 and alpha 2, and we have alpha 1 for selective. And we have done that alpha 1 acts on blood vessels, alpha 2 acts on presynaptic. Okay, presynaptic inhibition is caused by alpha 2, and alpha 1 acts on blood vessels. Now, names of drugs for alpha 1. Famous drug, prazosin, terazosin. You should note prazosin as one example. Terazosin will be remembered automatically. Then for non-selective we have phentolamine, famous drug, and P has come, so we have phenoxybenzene, benzamine, phenoxybenzamine. So selective are the prazosin and terazosin, and non-selective are phentolamine and the phenoxybenzamine. Okay, now combined effect will be vasodilation, decrease BP. Okay, but one additional feature, since the non-selective also acts on alpha 2, so we see increase noradrenaline levels. Since noradrenaline levels are increased, we see tachycardia. Okay, and here it acts only on alpha 1 and not alpha 2, so not so much changes in non-adrenaline. So tachycardia is minimal. So this is the difference between selective and non-selective alpha blockers. Okay, now coming to one more class, vasodilators. This is the most shortest and most easiest class, because we have much more lesser drug. Mechanism of action will be vasodilation, the name itself says. Okay, administration. Now it can be given orally, it can be given IV, also it can be given topically. Topical is specifically for minoxidil for hair growth. Okay, now the drugs. We have the drugs, just a second, MDHN, the main drugs. We will discuss one more drug then. M is minoxidil. It is the drug of choice for alopecia. Okay, topically. Okay, then we have the diazoxide. Diazoxide is an IV drug. It is an IV drug, and IV drugs are used for, yes, emergency. Then we have hydralazine. We have nitropuruside, and to add one we have sodium nitropuruside. Okay, this is a venodilator. Minoxidil is a artery dilator. Okay, and sodium nitropuruside, it is due to, like, it is a venodilator. Then we have one more drug, nitroglycerin, and it is also a venodilator, and for nitropuruside and for nitroglycerin and venodilator. And we have phenol dopam. It is not related to like proper vasodilator, but it is a D1 agonist, so peripheral arteries are dilated. Okay, D1 agonist. We have minoxidil, diazoxide, hydrazine, sodium nitroprusside as the main drugs, where the minoxidil, you should know, the drug of choice for alopecia. Then nitroprusside, venodilator, and nitroprusside is one of the most important drug. It is shortest acting, and the duration of action is short. It is rapid acting and administered by IV. Okay, and it is unstable in light. Okay, so it decomposes on exposure to light. And side effects are flushing edema. Okay, so just to write flushing and edema. So we have done with the 6 classes, and diuretics will be discussed earlier in renal pharmacology. Okay, now one last point, very important point: hypertensive emergency and urgency. Okay, so what is hypertensive urgency and what is hypertensive emergency? Okay, so BP systolic more than 180 millimeter of mercury, and diastolic more than 120 millimeter of mercury is hypertensive urgency. Plus, if we add end organ damage, for example retinopathy, it goes into hypertensive emergency. Hypertensive emergency, hypertensive urgency. Okay, so now what we prefer in these situation? Obviously IV drugs. So we will list the IV drugs. We have sodium nitroprusside. Okay, we have labetalol. Okay, we have nicardipine. Okay, we also have nitroglycerin. These are all given IV dose. Okay, in 1 hour we have to reduce the BP. Okay, then we have to reduce the BP further to 160 by 100 over 2 to 6 hours. Just let me write reduced BP in 1 hour. Then below 200. Then decrease BP further to 160 by 100 in next 2 to 6 hours, and normal in 48 hours. Okay, these are the objectives, therapeutic objectives. So this was all about hypertension. We have discussed all the classes except diuretics it will be further covered. We haven't discussed in detail about vasodilators. Vasodilators will require one more lecture, but this was all about treatment of hypertension. Thank you.